The vision of SIGN is creating a quality of fracture care throughout the world. We've tried to follow our vision in every decision that we make, and this is a very important statement to us. This video that we're going to show gives a little bit of a synopsis of SIGN, what we do, shows the patients, which are the real crux of our goal, and I hope you enjoy it. The past 20 years of working with SIGN have been like climbing a mountain. I remember that Nelson Mandela talked about climbing a mountain. He said that I've worked hard for the past years to climb the mountain, and I'm tired. And when I get to the top of the mountain, I will get a chance to rest. But when I reached the top, there was another mountain to climb. And that's the story of SIGN. We've been working for 20 years with many agonies and many ecstasies to help people around the world, to help the poor who have fractures. Incidentally, for you medical students, this whole relief effort was run by Pakistan medical students who contacted people around the world to come and assist them. The man in the bed is a very important symbol for us. He was one of the agonies. I had taught in this country for many years, for about a month out of every year, giving lectures. And I went to Vietnam and then came back to Indonesia, where this man was. One of my students was there, And we were making rounds, and we saw this man, as well as many other men on the ward like him. He'd had a fractured femur, and he had been in the traction for 3 years. He was depressed. His family stopped coming to visit him because they couldn't afford the small daily hospital charges. And I said, why? Why is he still here? We talked about this, we lectured about this, and you know how to fix these fractures. And the surgeon said, he cannot afford an implant. He said, and by the way, the implants that you send over here are made for United States, and we can't use them because we have power surges. And these power surges prevent us from using any power equipment such as instant imaging or even reaming. So I returned home to Richland, Washington, where we started working on a way to circumvent the use of electricity. Gradually, we evolved a model of education plus donation. They had to be donated because the poor cannot afford implants, and the implants had to be appropriate. Now, we have worked on all three of these factors: education, donation, and appropriateness of the implant, and I'll tell you a little bit about this. The C-arm is considered indispensable for treating fractures in the United States and other developed countries. It's where you can make instant images to know the position of the screws and to put that screw through the bone, through the slot of the nail, and out the other side without looking at it. We developed a way to do this with slot finders, and I want to say that many people have helped sign, and many people continue to help sign. So it's almost a global effort to help the poor in developing countries. We had to realize that the canals were different around the world. They have the same basic shape. By the way, we have more sameness and more similarities throughout the world than we have differences, but we have to account for the differences. Differences in bone density, differences in the curvature. So we had to make a condition that could suit and fit many canals around the world. It had to be economical. And I want to give credit to many people that I won't name because there's so many of them who helped us in this effort. We started off as a tibia nail. The tibia, if it has an open fracture, that means the skin and muscle above the fracture is opened, has the worst results because there's more infection there. There's not as good a blood supply, and the bone is nearer to the skin. So we started off with the tibia, and it worked really well. This fracture here was one of the first ones in Vietnam, and it was done without a C-arm. Remember, we had to put the nail down through the canal of these fractures to accomplish this. This girl showed up with a fractured femur and tibia. So we thought, what can we do? We went home as usual and thought about it that night, and came back in, put the nail down the tibia, and then we ran another nail up through the knee, up through the femur. This was new at the time. There was one article in the literature that I learned many years later in retrospect, but this was a new concept, and it worked well. We were communicating back then by mail and by picture. And this picture came in of the girl standing on her fractured leg 6 weeks after surgery, which was very encouraging to us. I then received another email with pictures from Han Khoi Quang, who was a good friend in Vietnam. He said we put the sign nail through the proximal femur to take care of those fractures there, and it worked really well. You can see by the x-rays before the surgery and after the surgery. And I said, oh no, we're going to have to invent and innovate a new nail. But he said, no. He said, just put the nail in and let it rotate where it will. And this has worked very well. We've not had to revise or change the shape or anything about the sign nail for the past 20 years. And I give the credit to the Vietnamese surgeon for helping us here. This man is from India, where they eat with their hands many times, and he had had 6 operations. He finally had the sign nail and his fracture healed. If you look at the bottom of the nail, it looks like it should be blocking motion, but you can see the motion that he has. And this was started by an Indian sign surgeon. We then started working on the hip, and we had to develop a modular system, a system that could be used for many different sizes of hips and many different types of hip fractures. So it's modular, different sizes of the implants, and you can use different combinations, and this turns out to work very well for us. This is one of the first cases in Afghanistan. This man is helped up by his family to mobilize. In the developing countries, most of the physical therapy is done by families, and he did very well. This young boy in Mongolia was the first pediatric nail in Mongolia. Here he is standing on his leg after surgery one day. He did very well. Also, and the Mongolians have led the idea that you can put a nail through the bottom of the femur, up through the growth center, without causing damage if it's done in a specific way. This young boy was climbing a mango tree in Kenya and broke his femur after he fell out. He's out in the field looking at that mango tree again, just showing that he feels no disability after his surgery. When we first started teaching sign, we traveled to different countries, we gave lectures, and then we operated together to learn the sign technique. So we combined a lot of different kinds of learning, and this was very helpful for us. But unfortunately, nowadays, we have so many surgeries, we have so many programs that we can't go around every program. So we've had to lean more toward digital teaching, and this is working out very well. The Sign Conference is held every year in Richland, Washington, but we have conferences around the world in order to teach. We still use the older methods of lecturing, but we have many breakout sessions now at our conference, including a bioskills lab for the difficult fractures. Procedural memory is very important. This means using your hands to accomplish what you've learned, and this is a very important aspect. It works well, and we try to use as much hands-on training as possible. We make our own implants here in Richland. We have a wonderful staff here who work hard to manufacture, innovate, and evaluate our implants. Creativity is, in fact, intelligence, having fun, according to Albert Einstein. And we agree with that, and we practice creativity here at Sign as we learn more about fracturing. We even are starting to do machine learning to evaluate the fracture site. So as we start our second 20 years, the connector between the two mountains is our database. the database is so important for us, and because it helps evaluate the past and looks at where we can help in the future. It connects surgeons around the world in 51 countries. Site trips are made to teach our complex fractures as well as the sign technique, and the sign conferences are always well attended. The database evaluates the sign surgery, as I mentioned. There's 144 surgical reports because we didn't start it right when sign started, because we didn't have the technology. Now we use the database to evaluate new ways to treat fractures and to evaluate whether we should intervene with more surgery if the fracture looks like it's not healing fast enough. We're dealing now with complex problems. We want to help deformity. We want to help patients with pelvic and acetabular fractures, and we're looking at patients that have spinal trauma to help them. These three complex problems require hands-on work. They require working under the supervision of a mentor for sometimes months, and we've started our pelvic and acetabular fracture fellowship in Ethiopia. Deformity is important. Deformity, these kids with deformity stay home. They don't have a hope of living a normal life, so we want to help them. This was done at the Tibia Hospital in the Philippines. Mentors are rising. This is Sami Hailu from Ethiopia. We're at a conference in Kenya, and he's teaching how to do pelvic surgery. And this is very important. The two aspects. One is the pelvic fracture surgery, but also the mentors are coming from developing countries. These surgeons are really good. In fact, they're as good as any surgeons in the world. They have it hard because they don't get preformed plates, pre-contoured plates that you can buy here. They have to bend their own plates. They don't have C-arm to use, so they have to be more skillful with their hands, and they are. Spine trauma is important. Right now, the patients that have spine trauma in many places are not treated appropriately. So we're using our model of education plus donation of appropriate implants. And this is the hardest part, to get the appropriate implants and to use our database to evaluate what we've done in the past and what we can do in the future. Sign has attended disasters in Indonesia on 2 occasions, and then in Banda Aceh for the tsunami. In Pakistan, we were asked to go to treat the people, and Haiti was another disaster where sign played an infinite role. In Nepal, 95% in Nepal, 95% of the patients with fractures were treated by sign surgeons. We decided that the best way to prepare for disasters was to establish programs in the countries which are likely to have earthquakes and supply them with the equipment. And we're very pleased that sign surgeons have taken charge of disasters in the Philippines and in Nepal. This Venn diagram gives an idea of the complexity of sign. Education is very important, but education intersects with the database, because we use the database both to evaluate what we've done and what we can do in the future. Education and the database interact with implants because we can innovate appropriate implants. And the elephant in the room is funding, because we are having a bigger and bigger budget every year. But I want you to notice that in the middle, that intersects with all of these aspects is the patient. The patient is first priority for us. This is a very famous saying about give a man to fish, feed him for a day, and teach a man to fish, and feed him for a lifetime. This was recently stated in an article by Haitian surgeons about sign in Haiti. And we strongly believe in empowering our surgeons. There's a challenge, however. The challenge is that poverty is decreasing. Well, that sounds really good. But this enables people to buy a motorcycle. And the motorcycle becomes the family vehicle and a way for the wage earners in the family to go to work. So the motorcycles are crowding the wards, fractures are increasing, and it's very difficult now to accommodate these. This is an example of a motorcycle becoming the family vehicle. The patients are ending up in emergency rooms. This is an emergency room, and they're not even in the ward yet because there's no beds available. And then when they get to the ward, they have to wait for operating time. So it's a difficult problem. It involves many facets of treating, and we have to look at the whole thing. So the challenge is education because there's not enough surgeons in developing countries. And so many of the sign surgeries are done by non-surgeons. Facilities, there's not enough operating rooms, so we want to be more efficient. In the United States, trauma centers serve that role because they treat the patients right away and they can treat more patients. Appropriate implants are important because now they have to be affordable and effective, but they have to be able to be used by non-surgeons, and we have developed implants to serve that role also. The sign response is continuing innovation, as we are doing, and looking with new eyes. And this is an important aspect. Proust stated this, and I'll show a little later. Looking with new eyes means looking at situations differently than they've been looked at in the past. Conventional wisdom must be proved because conventional wisdom changes with time. And we also are developing more efficient education using the internet. This is one of our innovations. This is the fin nail. It doesn't require that screw be placed through the end of the nail, as I showed earlier. They can be done in about 20 minutes, and they work very well. We're testing now the stability. We're re-looking at the whole fin nail design and results, and we are very pleased with this nail. This man, he's from Italy, went to Kenya as an infectious disease doctor. He asked for sign because he saw a big need in Kenya for sign. He was in a rural hospital. He's now done 1,000 surgeries in the past 3 years. And he's learned how to do surgery. These aren't just done surgeries. These are well done surgeries. And we are very pleased to work with surgeons like him who really want to learn and really want to help the people. He gets referrals all the way from Nairobi. We're learning from the fractures injured by conflict. This is a gunshot wound. We found we can put our nail in sooner for the gunshot wounds. They heal quicker. And why is this? Well, we asked an engineer about it, and he stated that the mechanical trauma of the blast stimulates the stem cells in the cortical bone, which stimulates healing. And this seems to work very well. So we developed a bone mill, which can grind up the bone fragments, provide the mechanical stimulation, and we're now testing this. So it's important that we use our observations in ways that can be done, and we're very happy with this approach. It works well with sign because we don't have C-arms, images in the operating room, and many times we have to do open reduction, and the open reduction gives us the opportunity to get the bone necessary for the bone mill. We also want to treat the people in rural areas. This is in Myanmar. The patients in rural areas have severe fractures, and they can't get treated, and it really is almost a death sentence for them. They go home to die. This is run by Dr. Ong, who's holding the suitcase, and he travels around rural areas showing the surgeons how to do sign surgery, and they continue to do that. And now he's requested another set because this is a very popular program. They communicate by Facebook and WhatsApp, so they're using the latest internet technology also. So as you go through your medical school, you may wonder why you have to learn different aspects and different disciplines such as biochemistry and microbiology. All of this will come together later on when you decide on your specialty. And I didn't realize this until recently when I travel. I can remember things back to medical school which have been very helpful. This young man epitomizes our model. Education. The surgeon was educated in Tanzania, and he returned to help people in South Sudan. This young man is blind, homeless, starving, and lives in South Sudan. I don't know how you could get any lower than that, but he got hit by a car. And the surgeon, Mapur there, paid for his antibiotic, treated him, and he's standing one day after his fracture. So at least he can return to moving around looking for food. This young girl is the mother of 3 children, and she's pregnant. Her husband killed in the war. She was up in a tree to get leaves to boil because they were starving, and she fell. She fractured both of her femur. Mapur, who's standing next to her, put in 2 fin nails, 20 minutes apiece, and she's standing one day after the surgery. So we're able to help many people, and this is what keeps us going when we hear these stories of patients that have been helped. This young man, as in the rickshaw drivers throughout the big cities of Bangladesh, was sent into the big city by his family out in the rural area, and he sends his money back to support his family. These rickshaw drivers have a lot of accidents, and therefore sign is used to help them. We're very happy that we can do that. Incidentally, these rickshaws are very difficult to drive. They only have one gear, and so these young boys really need to be commended. An injury affects the whole family. The father was injured. These are the 3 kids and the mother there, and WHO statistics state that the family spirals into poverty for 3 generations after a wage earner or parent is injured. And this is a very important aspect, that we can treat the family as well as the patient. This is one of my favorite pictures because this young man in Myanmar supports his parents and his siblings. He broke his femur, and here he is squishing noodles 2 months after his surgery. It's an excellent result, and I just love to see these patients back to their former occupation. Our sign staff is wonderful. We all work together. They're coordinated by Gene Dillner, and we all work together toward the same goal. We're like a big Venn diagram. This is our last sign conference. You can see the assigned surgeons, and they're very avid learners, and they talk among themselves and they share ideas among themselves, and it's really fun to be a part of that conference. The way forward is that we have many decisions to make when we're doing surgery or when we're seeing a patient in the office. And one of these is when to intervene in the healing process. This fracture is a failed plate, and by the way, we see many of these, and we wanted to give him the best stability we can. Well, this was done by antegrade approach, but we favor the retrograde approach for these distal femur fractures. In fact, we use the fin nail. But this was done post-operatively, and this is how he looked at 6 months. It looks like a non-union, but on the other hand, he can squat and smile. Those patients now, we wait. We don't intervene on, and we find that most of them go on and heal, as this patient did at 12 months. So this is important to tie in the clinical as well as the x-ray, and it also works well for us because many patients have been operated on and they live a long way from the hospital. They live a long way from the hospital, and so they can send a picture of themselves back in squatting and smiling, and we get some feedback that way. We're also making better implants. This is our fin nail. The fin nail, as you can see, does not require a distal interlock because the fin embeds into the side of the canal, but the nail also provides three-point fixation. And this works well. We are studying this to look at the indications for using the fin nail, and we're finding that they are increasing. When we first started using the fin nail, we suggested it be used only in stable fractures, which would be transverse fractures. And we wanted the fin to end up in the isthmus of the femur. Our assigned surgeons gradually expanded these indications. So now we are assaying how stable it is for comminuted fractures. Humerus fractures have also been treated with the fin nail with very good results. This patient, which we'll talk about later, is a 7-month post-op. He's healed well. And look where the end of that nail is, where the nose is, and look at the motion of his elbow. We still need to work this out, but it's this idea of using the fin nail in the humerus is working very well. These fractures are difficult. The subtrochanteric fracture often slides into this deformity, and also the implants break. We weren't satisfied with this, so we added a plate to the nail like this. We attached the plate to the interlocking screw, and this has provided excellent stabilization so that the patients don't need further treatment, and the results are very good. We also have modular implants. That means that we want to be able to accommodate different shapes, different fractures, because the hip fractures are very comminuted many times they're different fracture lines, and we have to accommodate different sizes of the people around the world. Our goal, therefore, is for these children to grow up, and if they have an orthopedic injury, to be disabled as least possible amount so they can live happy, normal lives as they're living now. Thank you very much.